Here's the heart. Let's take a look at this diagram I got, or this video I have flowing here. Sinoarterial node. I'll be talking about this concept. It's going to cause a contraction of the atria. Now, oh, look at that. Okay. That impulse is going to spread and cause a little contraction so that blood pours from the upper atria, there's two of them, into the ventricles down below. Now, of course, our blood is not blue. This is a diagram to show deoxygenated blood. It's really dark red. And then the oxygenated blood that just came from the lungs tends to be almost, well, not pink, but bright red. And you can see the AV is going to pick up the impulse. And then this impulse, we're not done with this impulse. It's going to travel down through the AV bundle, or bundle of His, same thing. And it's going to keep moving down into these Purkinje fibers. Well, there's left and right bundles. And it's going to flow over the heart. Because think of the goal here. The goal is to pump blood either to the lungs to pick up oxygen or to the body to keep us alive. More on that later. Pericardium. This membrane surrounds the heart and keeps it anchored, but it also allows the heart to beat. Now there's a fibrous layer that connects to the diaphragm, and I like that because when we breathe, we get a little boost of blood flow from the pressure of the diaphragm. Inner serous, let's take this diagram below. We have the fibrous on the outside. I talked about that one. And then the serous inside. The parietal is kind of mid, and the visceral is right up against the heart. Now, one of the important concepts of this is that sometimes fluids get in here and we have inflammation, but rare. Okay, rare. Three walls of muscles. The epicardium is on the outside, and this diagram doesn't show it, but as we age, we get a big sheet of adipose here, or fat. But we need the blood vessels and the nerves often to signal. It's often a warning system when there's a problem. Myocardium, this is the workhorse in the middle. It's striated just like skeletal muscle, but it does have these interconnected discs called intercalated, and so we get these crisp contractions of muscle. Finally, the endocardium, which is very small, up against the blood vessel wall, is very slick, so that we don't have sluggish blood flow. Sometimes this area gets infected, and same with myocardium and epi. All these layers can become inflamed. CPR, if you're wondering what they're singing here, it's the, if I can get it go, okay, we won't worry about it. Hands-on only is the preferred method of resuscitation, if I could say that word right. And that's because we want to get infected by a victim if we can keep them alive without using mouth-to-mouth. Here's a bag valve mask, which I like, BVM. And look out, this is the proper way to hold it on the patient's face. It needs to be really snug. It's hard to do this by yourself because there'll be some leakage. And so it's, in a way, we have a three-person life-saving, because someone else is providing compressions right there. This is, staying alive. Ha, 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 staying alive. It's trying to say 100 beats per minute is approximately the beat of that song, about 2 inches deep on the sternum. It's an old flick, yeah. Okay. Pericarditis. I talked about the pericardium, and I did mention how we can get inflammation in here. Virus, bacteria, binge drinking, drugs. Lots of things can cause this sudden inflammation of the tissue. And we hear this pericardial friction rub. It's like a creaky, scratchy sound. You can auscultate it with a stethoscope. I mean, you can't hear it without some assistance. Usually self-limiting, means it goes away on its own. Chronic is a little different condition, often due to fluids that have accumulated, and this is not good because the fluids will, well, there's not room for fluids, and so as fluids accumulate, then that applies pressure to the heart, and it'll change blood pressure, and it can lead to damage, permanent damage. Myocardium, I talked about that. Remember, that's the workhorse, the thick part. That's inflammation, myocarditis. There's an itis suffix, so you know there's inflammation going on here. It's in the endocardium, which I mentioned inside. And also the valves are lined with some endocardium. Atria is plural for atrium. And the intro video we saw there's 2 paired atria and 2 paired ventricles. Remember, this is your patient's heart, so it might look like this is the right side to you, but this is your patient's left side. They're laying down on the gurney in front of you. There's sulci, or sulcus singular, and those are depressions that I'm going to talk about where these coronary arteries reside. Nice little depressions. So I'll get to the coronaries. Let's talk about basic blood flow. We have the right atrium, the AV valve, right ventricle to the lungs. Okay, so AV lungs, left side AV body. Now the pulmonary system is going to be all this blue right here because that pulmonary is lungs. So this is the part of the heart that is pumping blood to the lungs. Systemic is on the right side, the left side, excuse me, with the red. It's pretty neat how these papillary muscles contract, because think of this. All right, let's take a look at the right side, because I'm showing a bicuspid, which is on the right. Tricuspid on the right, because you always try something before you buy it. So tricuspid right, bicuspid left. So let's look at the tri. Oh, if I can get it straight, bicuspid here. When the ventricle contracts, we want to make sure that blood flows to the aorta. We don't want blood to flow backwards. And so the job of this chordae tendineae here, these bands of cartilage, and the papillary muscles is they're going to remain open and relaxed as blood flows from the atrium to the ventricle. But when the ventricle contracts, we want that papillary muscle contracted so that we get a closure, and then blood doesn't flow backwards. It flows forward through the aorta and to the body. Systemic, yeah, I've pretty much covered this. We have the atrioventricular bicuspid on the left side, papillary muscles. I talked about how the bicuspid is going to open during atrial contraction, but it's going to close during ventricular contraction so that blood goes in one direction. Coronary. I started talking about this when I mentioned the sulci or the sulcus. You see, blood needs to travel. The heart wants to feed itself first. Very wise in that way. So we have the left side, the coronary artery, the left side coronary, is going to descend through this descending, or I call it the interventricular artery. I like that. Well, they're both good names. Interventricular means inter means between, ventricular means between the ventricles. And indeed, that's what it does. It's going to supply blood to the walls of the ventricle. It's also going to divide off into the circumflex. Think of circum as being around. And it does go around and carries blood to the left ventricle and the atrium. Now, we need the right side to stay alive, so we have the right side coronary. And look to the, see that faint line? That's showing, the artist showing the back of the heart. So there's a posterior descending, or also called the interventricular. And the marginal branches off down along the margin of the heart. Good names. Coronary circulation. Blood from the myocardium is going to drain into this huge coronary sinus. Okay, so we're looking here at the sulcus, and this one doesn't have any smooth muscle, so it doesn't contract. It doesn't. It's mostly storage. And into this is going to pour. Well, let's take a look at these lower diagram, because here you're seeing the anterior view where my pointer is. So you're going to see the great cardiac, and you'll see the small cardiac veins, and they are going to dump into the coronary sinus. Then if you look at the back of the heart, you're going to see the middle cardiac coming down there. Autorhythmic. Okay, so many of the tissues in the heart maintain the heartbeat. The main one we saw in the video was the sinoarterial or SA node. It's going to generate the initial signal that's going to cause the atria to contract. We saw those little yellow lights flashing here. And so the atria contract, the AV valve, of course, opens, and we get blood pouring into the ventricles. Now, the contraction isn't the only way, because changing pressure also causes blood to flow here. So I think atrial contraction is only about 25% of the blood, and the rest of it just pours in because pressure differences. That's more than we need to know. Atrioventricular node picks up the signal, but it stalls it a little bit. That way the atria can fully empty into the ventricles. Because once we get the impulse flowing down the bundle of His and on into the Purkinje fibers, then we want the blood to flow directly into the lungs or the aorta I've talked about, and we want the AV to snap shut. When the SA node is damaged, the AV is going to pick up the workload, which I can't see that well, but only about a rate of 40 to 60, but it keeps us alive. It's kind of neat that the heart has a backup system. But if the AV is damaged, then we have a problem, because autorhythmic fibers such as the Purkinjes and the bundle of His, they can only keep us going at 20 to 35 beats per minute, and we're going to die. Unless we have an artificial pacemaker, which is put below here. Here it is. I'm sorry. The left side under the superior, inferior to the clavicle, just under the skin, usually left side. And that's why when you do a AED, you don't put the paddles on the patient's left side. No. Just in case. This is Bruce Lee. We don't do we don't hit people's chest hard, because that can interfere with the electrical system. Some people have died through a blow to the heart. EKG or ECG, electrocardiogram, is going to record the impulses that we've been talking about. My favorite diagram is this one right here, kind of in the middle. We can see atrial contraction. We get a little P wave impulse. Then when the ventricles contract, which is a massive contraction, because remember the size of the myocardium, then we get this Q or S rise on the ECG. Then we have a little space, and then usually a small blip at the T wave, and that's when the ventricles relax. This is what we expect to see. Small P, big QRS, little ST segment, and there's the T, the small blip when the ventricles are relaxing. We don't want to see tachy, ventricular tachycardia, because think about this. It looks like great pumping's happening here, yes? But there's not sufficient time for the atria and the ventricles to fill with blood. It's like trying to run a car on an empty tank and try to get their engine running. VFib is also, it's a little more random in its impulses, but we don't have that filling of the ventricles and atria. And without that, well, this one we have to usually use an AED and try to reestablish a normal rhythm. Okay, we'll stop here.